So, uh, giving me immense pleasure to welcome all the participants and dignitaries for the fourth day of the FDP, sponsored by EA. So, you all are able to add some, we are able to add some knowledge or research in the area of drug delivery and nanotechnology. So, uh, I hereby welcome, although virtually, our esteemed speaker of the day, Professor S.K. Jain, to our university and to this 5-day FDP program. Sir, you are truly an inspiration to me and several thousand students and scholars across pharmaceutical domain. So with this, Dr. Professor S.K. Jain is currently head of department at Dr. Singh Road, Central University, Sagar. He is the chairman of Council for Industry Higher Education Collaboration and University Innovation Council. He is the chairman of University IPSL 2. He was former dean for School of Engineering and Technology, and with over 30 years of experience, more than 30 years of experience in teaching and research. And uh, uh, 2 years more than he has chapters. He has national and international patent to his credit. He has filed several patents which are due to be granted to him. His main area of research is design and development of various novel drug delivery systems for the treated. Recently has been confirmed in 2018 the highest and very prestigious Visitors Award. Honorable President of India, Shri at Rashtrapati Bhavan, has been awarded 2006 to 2092 with IDMA Award for Best Paper Award, Best Research Paper. Besides this, he has been conferred the Female Award in 2009, TRS Capital Fire Innovation Award USA in 2000, Best Research Award in Technology, then award by European Technology. The recipient of RQ for the National Excellence Award, Lifetime Achievement Award was confirmed to him by National Conference by SIF ES Sagar. He has successfully guided 26 PhDs to a huge number and more than completed half of dozen major research projects funded to him by various national agencies. He has presented he's a renowned scientist and academician throughout the world, and he has participated at various at national conferences and invited. He's a very renowned and speaker for various technical and scientific events. He's a member of reviews in therapeutic drugs and career. He's a regional editor for current signal transduction therapy by Pharmaceutical and Bentham Science Brand Ambassador. He is also referee for various national and international journals. He is on the board of reviewers and the chairman of national and international board for taking care of the research projects, sanctioning of research projects. He is the chairman of University Technical Committee. He is a member of board of studies for various universities and so more. Right? I keep on reading this, the profile of Professor S.K. Jain at the time. I will take a lot of time. So without taking much time between you and our first speaker of the day, Professor S.K. Jain, now I would like to invite Professor Jain to deliver his on nanotechnology. So with this word, now I would like to invite Professor S.T. Jain. Sir, over to you.
Thank you, Dr. Amit Bhatia, for giving my introduction to the participants, learned participants. Before starting my deliberation, I would like to thank Professor Bali for. I'm audible. Am I audible?
Yes, sir, you are audible.
Okay. So, well, first of all, I would like to thank Professor Ashish Bali for inviting me and share my views about the nanotechnology. Basically, my research field is also on the nanotechnology. I am especially working on for targeting drug to the colon, that is the last part of the gastrointestinal tract, and delivering drug to the brain. These are the two parts of the body where delivering drug is very difficult, or targeting drug to this part is really very difficult. And here the technology is required to deliver effective concentration of drug to these parts for the treatment of diseases associated with these parts of the body or these organs of the body. So, well, today we'll discuss about the how will you deliver drug to the colon, how will you target drug to the colon using the nanotechnology based strategies, how will you target the drug to the colon. And may I share my slide?
Yes, sir. Please share. Yes, now it is visible, sir.
Yeah, just a minute. Well,
Oh, this is fine.
fine. Okay, thank
Yes,
you.
sir.
Thank you, Amit. So, well, today we'll discuss about the nanotechnology-based drug targeting to the colon. So, here we'll discuss different approaches or strategies which we can use for targeting drug to the colon, especially for the treatment of the diseases associated with the colon, like psoriasis, colorectal cancer, inflammatory bowel disease, Crohn disease, ulcerative colitis. So these are the diseases where the treatment is really very difficult, or we can say the management of these diseases is very difficult. It is because we cannot deliver drug in effective concentration to this part of the gastrointestinal tract, this part of the gastrointestinal tract. So we use some studies for targeting effective concentration of the drug to this part of the gastrointestinal tract. So before discussing different stages, we must have to know about the anatomy and physiology of the colon and different problems which are associated with the colon. Then we can design some stages for effective delivery of the drug to the colon. So especially being in the pharmaceutical sciences, we are delivery of the right whatever way. Third order targeting, that is the intracellular targeting, that is the inside the cell or in between the cells, that is the intracellular targeting. So there are three order of the active targeting: first order targeting, second order targeting, and third order targeting. And the passive targeting is in which the body natural response of the drug is used for targeting the drug, like RS take of the RS system find more by this passive targeting. We can target drug to the this liver or spleen by this ice uptake. Now come to the colon, and in the colon you will find this is the, as you the last or lower part of the gastrointestinal tract. It extends from the ileocecal junction to the anus, and colon is upper 5 feet of the large intestine, and rectum is the lower last part of the gastrointestinal tract, that is in 6 inches. Apart from that, if you see the anatomy of the colon, then you will find the colonic membrane is very complex membrane. It is having number of membranes like mucosa, that is just the luminal side. Then below the mucosa, you will find submucosa, then cellular mucosal layer, then longitudinal muscles layer, and then the serosal side. So if you deliver any drug into the colonic, you are able to target drug, or you are able to deliver drug to the colonic lumen. But same time, if it is required to absorb through the colonic membrane, it has to cross all these barriers. Then it will reach to the serosal side where the blood circulation is there, and through that drug will be circulated to the whole body. Or so it is really very difficult to get drug absorbed from the colonic epithelial membrane. That colon is the potential site for the drug delivery. Why it is a potential drug delivery? Because it has very low hostile environment. We very less amount of the drug degradation we will find in the colonic environment, right? So it has very low environment, long colonic transit time. Long colonic transit means if drug is enter or any thing enter into the colonic colon, then what will happen? It has to take about 20 to 30 hours to come out from the colon to the rectum, right? So the transit time is very long, and because of this long transit with the drug delivery system about this enhancing the absorption, we can monitor the drug release and drug absorption from the colon because of long transit time. It has unique microflora. This is also very important. If you see the microflora in the subsequent slide, I will discuss about the microflora also, what type of microorganisms are present in the colonic lumen. Then you will find that in the colonic microflora is unique microflora. It has aerobic and anaerobic microorganisms, as well as because of if you see the colonic content, then it is full of the microorganisms. And if sometimes if you see the feces, in the feces which is coming out from the colon to the through the rectum, then about 30% weight of the feces is containing the microorganisms that are coming from the colon, right? So colon is having most of the beneficial microorganisms which are used for which are helping to digest the undigested meal which is coming from the upper part of the GIT. When I say upper part of the GIT, it means the large intestine and stomach. So the meal which is coming from the stomach or large intestine, small intestine to the large intestine. Colon, we can also call it the large intestine. When it is coming into the large intestine or colon, then the undigested meal will be digested with the help of these microorganisms. It is highly responsive. The membrane, a colonic membrane, is highly responsive to absorption enhancer. So this is and it is having very unique feature because for absorbing the drug from the colonic lumen to the serosal side, means to the blood circulation side, then you are required to change the permeability of the colonic membrane. Otherwise, it will not cross, because from the colon only small molecule water soluble water is absorbed from the colon, right? So that you are required to enhance the alter the permeability of the colonic membrane. Only then you can get absorb the drug from the colonic lumen to the uh, systematic circulation. There are two routes by which we can achieve this colonic delivery. One is the oral administration, and another one is the rectal administration. What happened in the oral administration? First, we'll discuss the rectal administration. In the rectal administration, drug has to travel very short distance, say like 6 inches or say 1 feet, 12 inches. Only that length drug has to travel. But administering drug through the rectal route is not easy task. Then you will require because you have to consider the transit time from the buccal cavity to ileocecal region. Ileocecal region is the last part of the small intestine, and from there, that point, the colon is started, right? Or large intestine is started. Okay, so that time is 5 to 6 hours drug has to travel if you are delivered through the oral route, means up to 5, 6 or 7 hours etc. So that we have to monitor, and we have to select accordingly. Then if you see the gastrointestinal tract, our gastrointestinal tract and length, pH and transit time of the gastrointestinal tract, it is having a lot of variation in the length, it is having a lot of variation in the pH, it is having a lot of variation in the transit time. And when we design any colon targeted drug delivery system, we must have to consider all these points. We have to consider the length of the that part of the intestine, and we must have to consider the pH and transit time of that part of the gastrointestinal tract. Say, if you see the stomach, all right, this is after the esophagus drug will reach directly to the stomach. In the stomach, then length of the stomach is approximately 20 centimeter, and pH is ranging from 1.5 to 2. And the residence time of the stomach is 1 to 3 hours, right? If you want to deliver drug to the colon, this time we must have to consider, right? And we must have to consider the pH. The delivery system has to be protected through this pH 1.5. It should not release drug. It should not release any drug at pH 1.5 or 2, right? So that we must have to consider. And then drug will reach to the small intestine. This is the small intestine, right? This is the small intestine. It is having the length of 730 centimeter, and the transit time of the small intestine is 3 to 5 hours, right? That we must have to consider when you are required to deliver drug to the colon. This transit time you must have to consider, and delivery system has to be protected from the variation in the pH in the different part of the small intestine. First is the duodenum. After the stomach, the duodenum, that is having the pH 4.5 to 5. Jejunum, that is having pH 5 to 6.5. Ileum, that is having pH 6 to 7.5. That you must have to protect your delivery system by this variation in the pH. Only then you can deliver effective concentration of the drug to this colon. Colon is this one, colon. Okay, and after that, this is the ileocecal region. This one is the ileocecal region, and from ileocecal region, drug will reach to the, or the meal will reach into the, from the small intestine to the large intestine or colon, we can say. First, it will the ascending colon, that is having a length of 20 centimeter and pH is 6.4 plus minus 0.6. You can visualize that the last part of the small intestine is having pH. There is a gradual increase in the pH from stomach to the ileum, right? From 1.5 to 7.5. Then when the product of the small intestine or ileum will reach into the descending colon, there is sudden fall in the pH, right? From 7.5 to 6.4, there is a sudden fall in the pH. It is the fall in the pH is because of the presence of short chain fatty acid that is arising from bacterial fermentation of the polysaccharides like lactose to lactic acid. So because of formation of the lactic acid, the pH will reduce from 7.5 to 6.4. Then again, there is a gradual increase in the pH from 6.4 to 7 to 8, right, in the sigmoid colon. So they are a different part of the colon, the ascending colon, then the transverse colon having length 45 centimeter, and pH is 6.6 plus minus 0.8. Descending colon, this is the descending colon having length 30 centimeter and pH is 7 plus minus 0.7. And then sigmoid colon, that is having pH 7.4 to 8 pH, and then rectum, that is 12 centimeter in length, having pH 7 to 8. So this, when we design any drug delivery system that for colon targeting, and it is to be delivered through the oral route, we must have to consider the transit time as well as the pH, variation in the pH during the designing of the any colon targeted, colon specific drug delivery system. I was talking about the microbial flora in different part of the GIT, especially we are interested in the microflora flora of the large intestine or colon. Say, if you see in the upper part of the GIT, when I told you that upper part of the GIT means large, small intestine and stomach, then you will find that only 6 microorganisms are present in the upper part of the GIT. The Clostridium, then Micrococcus, E. coli, Klebsiella, and Proteus. These 6 microorganisms are present in the upper part of the GIT. But in the colon, that is, I told you, it is full of microorganisms. That is a long list of the aerobic and anaerobic bacteria that are present in the colon, and that are used for the digestion of the undigested food which is coming from the small intestine to the large intestine, especially bacteroids, bifidobacteria, Eubacterium, Peptococcus. These are the microorganisms, they are beneficial microorganisms. And I told you 30% of dry weight of the feces consisted of the bacteria which are coming from the large intestine. Then if you see the count, bacterial count in different part of the gastrointestinal tract, then you will find that the stomach is having a very limited number of the microorganisms ranging from 0 to 10 to the power 3 colony forming unit per ml. Jejunum is having 10 to the power 5 colony forming unit, and ileum, that is the last part of the small intestine, having a little bit larger amount of the larger number of the bacteria, that is 10 to the power 3 to 10 to the power 7 colony forming unit. And colon, that is in which we are interested. So having the bacterial count 10 to the power 11 to 10 to the power 12 colony forming unit per ml. So you can imagine that the population of the bacteria, population of microorganisms present in the colon. And because of these different type of the microorganisms that are present in the colon, they releases different enzymes, right? Reducing enzyme and hydrolytic enzyme, which are used for digesting the undigested food in the large intestine. So the reducing enzymes that are released by the colonic bacteria, nitroreductase, azoreductase, N-oxidase reductase, and sulfur oxide reductase. These are the reducing enzyme, and hydrolytic enzymes that are also released in the colonic lumen by the colonic bacteria. That is the esterases, amidases, glycosidase, gluconidase, and sulfatase. And because of release of these enzyme, number of metabolic reaction are carried by the bacteria, that is in the colon, that is the hydrolysis, reduction, and decarboxylation, dealkylation, dehalogenation, deamination, acetylation, and esterification. Right? These are the reactions are taking place in the colonic lumen by the release of the colonic by the release of the different metabolic enzymes by the colonic bacteria. Here we are interested in only these two enzymes that is exclusively released in the colonic lumen by the colonic bacteria. That is the azoreductase. Azoreductase released by the azobacters present in the colonic lumen. And that reduces, azoreductase is responsible for reduction of the azo bond. So they are selective enzyme for the reduction of the azo bond. If your delivery system or your drug is having the azo bond, then this azoreductase is responsible for its degradation. Polysaccharidase, which degrades the polysaccharides which are coming from the upper part of the GIT to the colon. So polysaccharidase enzyme is a different type of polysaccharidase enzymes are released by the colonic bacteria, and they are responsible for degradation of the undigested polysaccharides. As I told you that what happened, drug is not absorbed from the colonic lumen to the systematic circulation. It is because of the so many barriers are present in the colonic lumen. A small surface area, if you compare with the small intestine, it is having a villi, microvilli, right? Fold of Kirkland, right? Because of that, the surface area of this small intestine is very large as compared to the colon. So it is having limited surface area for the absorption of the drug. And there is a specific, non-specific binding of the drug with the dietary component as well as the product released from the colonic bacteria. So because of that, it is forming the specific, non-specific binding with the drug or dietary components or the product released from the colonic, and they may produce resistance for the absorption of the drug. High viscosity of the colonic content. If you compare with the upper part of the GIT, the content of the colonic lumen is having very high viscosity, which impedes the diffusion of drug from the lumen to the colon. Then mucous layer at the epithelial surface of the colon, it is having the thick mucous layer which darts the drug reaching to the epithelial surface. And this is a great barrier for the absorption of the drug. Unstirred water layer. This is the special layer you will find in the below the epithelial membrane in unstirred water layer. And that is the barrier for the absorption of the lipophilic drug because it is the hydrophilic barrier. And if you see the membrane of the epithelial membrane of the colonic epithelium, then you will find that it is having the colonocyte and occluding junction complex in the colonic epithelial membrane, which provides a physical barrier, right? So because of that, the intracellular absorption of the drug is not possible. Intercellular absorption of the drug is not possible because of presence of colonocyte or occluding junction complex. Epithelial surface, that is lipoidal in nature, and it is a barrier for the hydrophilic drug. So because of these barriers, only absorption of the low or only water or dissolved minerals are absorbed from the if you compare the colon-specific dosage form with the conventional dosage form, then you will find if you are required to deliver drug to the colon for the treatment of the colonic lumen, then you will find that if it is delivered through the conventional dosage form, right, it will go into the stomach, and the dosage form will disintegrate and drug will come out, and part of the drug may, depending on the physicochemical property of the drug may absorb either from the stomach or from the small intestine, right? Very little unabsorbed drug will reach to the colon for the treatment of the diseases associated with the colon. But if it is delivered through the colon-specific dosage form, then what will happen? Drug will be ineffective in the stomach. It will be ineffective. No drug will be released in the small intestine, and the whole amount will be delivered to the colon, right? So that is the comparison of the colon and conventional dosage form. Here it is another way of explaining the differences between the colon conventional dosage form with the colon targeted delivery system. Say what happened here, we take an example of very popular drug for the treatment of very common disease of the colon, that is amoebiasis. In that, for the treatment of amoebiasis, what we take metronidazole, say 500 milligram, 400 milligram, 3 times a day, means you will require to deliver drug to 1.5 to 2 gram daily, right? And multiple dosing. Just this much amount of the drug you will require for effective delivery of the drug to this colon. So can you imagine that for killing the tiny amoeba, and you were delivering say 500 milligram or 3 times or 4 times a day for the treatment of the amoeba, for killing this small amoeba? It is really very ridiculous one. What happened is, if we take the metronidazole tablet through the oral route, 95 or 98% of the drug metronidazole will absorb from the upper part of the GIT, from the stomach or small intestine, and through the blood it will go into the colonic region, right? It will go into the blood, and from blood it will go to the colonic region. So because of the absorption of 98% or 95% of the metronidazole, you will have a lot of side effect of that drug, right? And very small unabsorbed metronidazole will reach to the colon. But if it is delivered through the colon targeted drug delivery system, then it will not be absorbed from the upper part of the GIT. Metronidazole will not be absorbed from the upper part of the GIT, because no drug will be released at that part of the gastrointestinal tract. Means no drug will release at the stomach, no drug will release at the small intestine. So what happened, most of the drug which is administered through the oral route, it will be delivered directly to the colon. When it will, this colon targeted delivery system will reach into the colon, the delivery system will be degraded and drug will be released. So in that way, if it is metronidazole, if we design in the colon specific drug delivery system, then we can reduce the dose of the drug about say 90% dose we can reduce. Which drug candidate we must have to use for the colon specific, for designing the colon specific drug delivery system? Those drugs which are having the poor bioavailability from the stomach and the small intestine, like peptides or peptidal drugs, or those drugs which are having the deleterious effect on the gastric mucosa, then can also be used. Then drug required for the treatment of diseases associated with the colon. These are the diseases associated with the colon, where the drug is targeting is required, means drug delivery to the colon is required. That is amoebiasis, colorectal cancer, ulcerative colitis, inflammatory bowel disease. There are certain example of colon-specific drug delivery system where various drugs are used for designing the colon-specific drug delivery system for the treatment of the local action, topical action, or systemic actions. So digestive enzyme supplementary that are used for the cystic fibrosis, pancreectomy, or chronic pancreatitis for local action. Say, for the treatment of inflammatory bowel disease, Crohn's disease, irritable bowel syndromes, right? For the treatment of this, you will require a topical delivery of the 5-aminosalicylic acid and some steroid like prednisolone, sulfasalazine, ipsalazine, balsalazine, mesalazine. These are the product of the 5-aminosalicylic acid. So they are specifically designed in such a way that drug will be delivered. They are having the as bond in the skeleton of these drug, so that will not absorb from the upper part of the GIT. It will be really absorbed, or that this as a one will be cleaved, and drug will get the parent drug, that is 5-aminosalicylic acid, in the colon for the topical actions for the treatment of these diseases. Then for the treatment of colorectal cancer, 5-uracil is being used for systematic exhaustion, non-steroidal anti-inflammatory drugs, therefore that prevent the gastric irritation because drug will directly release to the colon. And typhoid for the delivery of the vaccine, typhoid vaccine, or insulin for the delivery of peptides for the systematic absorption. If it is for the systematic absorption, you will require to enhance the permeability of the colonic membrane. Only then it will get absorbed. Now come to the some technological aspect which or CG which we can use for the delivery of the drug exclusively to the colon. That is the so that having some advantage, oral nano drug delivery system for colon targeting, that is releasing drug exclusively to the colon, increasing colonic viability because they are small in size, so the viability of the drug in the colonic lumen is increased, enhance therapeutic efficacy by localizing drug to the colon, reducing systematic adverse effect by reducing the absorption of the drug from the upper part of the GIT, maximize drug utilization, and maximizing drug retention in colon because of the size that these system is increased in the colon. So there are different approaches that nanotechnology approaches we can use the colon. Size dependent nano design. This is especially in case of inflammatory bowel disease or irritable bowel disease, where the membrane is and ROS level is increased. Increase ROS this degrading this nano delivery system. That is not redox principle. So redox nano delivery system we can design. Active targeting dependent delivery system also design. That is especially for the targeting drug to the colorectal. On this approach, I received the President Award in 2018 by Honorable President of the India. Then nanotech-based app or colon targeting. Here, these approaches will discuss. These two approaches are not nanotechnology-based, but they are here. It is very essential to discuss about these pro-drug approaches and time-release approaches, because these approaches are also very important for targeting drug to the colon. So pro-drug approaches, that is having the pro-drug, cyclodextrin or product. Site-dependent drug delivery system, service charge-dependent drug delivery system, P-dependent drug delivery system, biodegradable drug delivery system, redox drug delivery system, active targeting dependent drug delivery system, and time release system. In time release means you are the transit time is from the buccal cavity to the ileocecal region is 5 to 6 hours. If you are able to delay the release, say 5 to 6 hours, by the time your delivery system will reach to the colon, ascending colon, right? So that is the time release, just of the drug to the 5 to 6 hours from the delivery system. This is the sulfasalazine is having the number of side effects which is caused by the this sulfapyridine. This is the byproduct of this sulfasalazine after the degradation. So sulfapyridine, because of sulfapyridine, will face number of side effects. That is why some other product of the 5-aminosalicylic acid are synthesized, which are having less toxicity as compared to the sulfasalazine. That is the valsalazine, epsalamine, right, or the olsalazine, right? They are having, say, valsalazine having the amino acids. The amino acid is conjugated with the 5-aminosalicylic acid with the help of the azobond, 4-aminobenzoyl beta-alanine, or 4-aminobenzoyl hippurate. They are conjugated with the 5-aminosalicylic acid with the help of the azobond, right? So you will get the prodrug, and which will exclusively deliver 5-aminosalicylic acid to the colon. So here azoreductase enzyme, which is released by the colonic bacteria, will cleave this azobond, will get the one molecule of the 5-aminosalicylic acid. But the most popular 5-aminosalicylic product for the treatment of 5-aminosalicylic acid is the olsalazine. Olsalazine is synthesized by taking the two molecules. Two molecules are joined together with the help of azobond, right? So when this olsalazine is delivered through the oral route, it will reach to the colon. The azoreductase enzyme will cleave this azobond, and you will get two molecules of the 5-aminosalicylic acid. This is an example of glycoside prodrug. Glycoside prodrug, what happened? There are a number of polysaccharidase enzyme are released in the colonic by the colonic bacteria in the colon. That is the beta D galactosidase, beta D glucosidase, alpha L arabinofurantosidase, beta D gylopyrantosidase. These are the polysaccharidase enzyme are released in the colon, right? So, and they are responsible for the degradation of the this beta glucoside bond in the which are program. This is an example of dexamethasone 21 beta D glucose. This prodrug is reach into the colon, right? This bond is cleaved. Glycoside bond will be cleaved by the galactosidase, glucosidase, polysaccharidase enzyme, and you will get the dexamethasone molecule. That is the active molecule. So this is the example of the product of dexamethasone and prednisolone have been prepared with the beta glucoside or beta galactoside bonding. Then cyclodextrin powder, beta cyclodextrin, might have heard about the beta cyclodextrin. It is very popular uh, ingredient for enhancing the water solubility of water insoluble drug by making the inclusion complex. If the drug, water insoluble drug, is encased inside this beta cyclodextrin, marking the water solubility of that water insoluble drug is increased. But if we conjugate with this OH, if we conjugate drug with the OH group present over the surface of this beta cyclodextrin, the conjugate will form, that is the beta cyclodextrin drug conjugate, having these are the bound together by the covalent bonding. So this will exclusively release the drug in the colon when the polysaccharides enzyme will be acting and release this drug, right? So this is an example of diphenylyl acetic acid beta cyclodextrin conjugate. And after the cleavage, the beta cyclodextrin is excreted unchanged with the feces. This is another example of dextran product, which is a drug which is conjugated with the dextran or exclusively degraded by the dextranase present in the colon, right? So there are two types of conjugation, succinate or glucarate conjugation you will find here, right? And this is an example of the product of methylprednisolone and dexamethasone. They are conjugated or glucarate and dextran. And half-life of this dextran or prednisolone is increased many times. Say dexamethasone, glutarate, dextran ester product, the half-life is 103 hours. In methylprednisolone, succinate dextran ester product, having half-life 82 hours. So in the presence of the dextranase enzyme, which is released in the colonic lumen by the colonic bacteria, it will degrade dextran and drug will be released. Another approach is that is the size dependent nano system. By making the size nano size particles, we can improve the colonic resistance time, especially in case of the inflammable bowel disease, exerting an epithelial enhanced permeability and retention EPR effect we can enhance, allow preferential uptake of nano-sized particle by immune cells, especially in case of the inflamed lesion, in case of the ulcerative colitis, inflammable bowel disease. Avoid rapid carrier elimination by diarrhea. In case of the inflammable bowel disease, there are one symptom is the patient will have very high diarrhea, and there are chances of clearance of the design drug delivery system. So if it is present in the nano size, then clearance can be reduced. MCL involved in the predominant uptake of the nanoparticle through the transcytosine. Then surface charge approach, nano relay system that influence the electrostatic interaction between the charge nanoparticle and inflamed cell. This is especially used for the treatment of the inflammable bowel disease. So colony specific nanoparticle, either if they are both are beneficial, cationic as well as the anionic nanoparticles are beneficial for enhancing the residence time of the these particles in the colonic lesion. So it enhances the adherence of the, if it is positively charged, then it enhances the adherence to the inflamed mucosa of the colon in case of the inflamed bowel disease. It reduces the nanocarrier clearance when intestine motility is increased. Because it has very high adherence with the inflamed mucosa, and mucous layer thickness thicker in Crohn's disease. It's a promising studies for targeting and retention of the drug delivery system in the colon, especially in case of the Crohn disease. They are a certain example of the positively charged nanocarrier system that are exclusively used for the targeting drug to the colon and for the treatment of inflamed bowel disease. Clone rate loaded nanoparticle comprising of cationic methyl methacrylate or hydrazate RS, titosin functionalized polylactic glycolide nanoparticles, titosin or pectin coated liposomes that are used for targeting drug to the colon, enhancing its adherence with the inflamed mucosa. Then negatively charged nanocarriers that also enhance adherence with the high concentration of positively charged protein in inflamed region, like inflamed region are having the certain proteins, high concentration of proteins like eosinophil, cation proteins, and transferrin. And because of that, they are positively charged proteins, so that there is charge-charge interaction with the nanoparticles, negatively charged nanoparticles. So they will adhere strongly with the membrane of the inflamed region of the colon. And so we can achieve the targeting of these particles with the colonic inflamed membrane. So if you compare what will be the effect of the charge on the adherence in the colonic membrane, then you will find that negatively charged are having the more adherence as compared to the positive charge and then to neutral nanoparticles. So this is the anionic nanostructure, negatively charged nano lipid carriers bearing venocyte. They are also used for the targeting drug to the colon. This is a very important and we can say very easy approach for targeting drug to the colon. That is by changing the pH. You know that there is a lot of variation in the pH from the top of the gastrointestinal tract to the lower part of the intestine. And that variation in the pH can be used for taking the drug release from the developed drug delivery system. So we can use some pH-sensitive polymers like hydrazides for targeting drug to the colon, like hydrazate L or hydrazate S that can be used because these polymers are dissolved at the pH greater than 6.5. So by the if we design any nano delivery system, nanoparticles using this hydrazate containing the drug, and when we administer through the oral route, these particles will be released when they will get these particles will start dissolving when they will get suitable pH that is above the 6.5. By the time it dissolves, then your delivery system will reach into the colon, right? So by this approach, we can using these pH-sensitive polymer, we can target drug to the colon. And some hydrazate-coated nanoparticles can also be used, or liposomes, hydrazate-coated liposomes can also be used for targeting liposomes or nanoparticles to the colon. But main drawback with this approach, pH-sensitive polymers approach, is that the inter-individual or intra-individual variation in the pH is more, and because of that variation in the pH, sometimes drug may release in the upper part of the GIT, in the outer jejunum or in the ileum. So this is the main drawback with pH-dependent nanodrug delivery system. Then biodegradable delivery system, as I told you, the two very important enzymes are released by the colonic bacteria, that is azoreductase enzyme, which are responsible for cleaving the azo bond. If the azo bond is present in the skeleton of the polymer, either in the drug or in the polymer skeleton, that can be used for designing the colon-specific delivery system, or polysaccharides, like there are a number of gums that can be used for making the nanoparticles of these gums, and we can effectively deliver drug because these gums are exclusively digestive when they will have the polysaccharides enzyme for its digestion. So that is exclusive present. Polysaccharides enzyme is exclusively present in the colon. So we can use either azoaromatic polymer where the azoreductase enzyme is acting, or we can use some gums like alginate, pectin, dextran, guar gum, chitosin for designing the colon-specific nanoparticles, where the polysaccharides enzyme is responsible for degradation of these polymers. So there are some certain example of, say, Saffron and co-workers prepared azoaromatic polymer using the styrene and HAMA with divinyl azobenzene. This is a cross-linker they use for making the copolymer of styrene and HAMA. So when they copolymerize it, they will have a azo bond in the structure of the copolymer, and that polymer will be exclusively for degradation in the colon by this with the help of this azoreductase enzyme. Similarly, Van de Mutter et al. Synthesized azoaromatic polymer using the HAMA or methyl acrylate or methyl methacrylate BMAV cross-linker. This is the styrene and HAMA copolymer, and here this is the cross-linker is used for synthesizing this copolymer. So either we can use divinyl azobenzene or NN bis beta styrene sulfonyl 4,4 diamino azobenzene. These are the two cross-linker, either divinyl benzene or NN bis beta styrene sulfonyl 4,4 diamino azobenzene. We can use for synthesizing this polymer, and these two cross-linker, with the help of these two cross-linker, whatever polymer will get, it will have azo bond in the skeleton of this copolymer. So this copolymer can easily be used for targeting drug to the colon, because this will not release any drug in the upper part of the GIT, because it will be unaffected, it will not get suitable environment. So it will get a suitable environment means the azoreductase enzyme it will get in the colon, and azoreductase enzyme will cleave this bond, azo bond, and the polymer become porous one, and drug will be released. So this is how you can prepare nanoparticle of azoaromatic polymer, right, containing the drug, and and this nanoparticles of azoaromatic polymer is filled in the hard gelatin capsule, and hard gelatin capsule is further coated with the entry-coated polymer, so it will be safe in the stomach. It will be intact in the small intestine. When it will reach into the distal part of the intestine, the entry coating will dissolve, and in the distal part of the intestine, the entry coating is dissolved, and then by the time the capsule will reach into the colon, and in the colon, the capsule will dissolve, and your these nanoparticles will come out, where azoreductase enzyme will be responsible for degradation of this azo bond present in the structure of the skeleton of the azoaromatic polymer, and drug will be released. Or we can do we can use azoaromatic polymer as a coating material also. So here we'll prepare the core tablet or core drug, right? In the core we'll keep the drug and coat it with the azoaromatic polymer. So this azoaromatic polymer coated that will be unaffected in the stomach and small intestine, and when it will reach into the colon, azoreductase enzyme will cleave the azo bond which are present in the skeleton of the azoaromatic polymer, and drug will be this film will become porous and drug will be released in the colonic region. Or we can have similarly, we can have this matrix of the polysaccharides like gums, right? So drug will be embedded in the polysaccharide matrix or in the gum. Then this will be intact in the stomach and small intestine, but only little swelling will be there. So little amount of the drug may release in case of the, if we use the polysaccharide or gums for designing the colon-specific degradation system. But when the swell system will reach into the colon, where polysaccharide enzyme will be acting, and this gum will be degraded, drug will be released in the colon. This is what we prepared, calcium pectinate microspheres in our lab, right? One of my PhD scholar prepared this calcium pectinate microspheres. So this pectin solution, 3% in phosphate buffer saline, is prepared, and it is dispersed in isooctane having pH, SMAN 80, right? And this pectin solution is also having 1% equal solution of clean 80, and drug is dissolved in this pectin solution or dispersed in the pectin solution, right? So we'll get the water in oil type of emulsion, stir for 10 minutes at 1500 RPM, right? And after mixing it, again we'll stir for 10 minutes, right, at same RPM. We'll get the dispersion. In this dispersion, when we add calcium chloride 35% dropwise, the calcium pectinate will be hardened, right? By reacting with the calcium ion, we'll get the calcium pectinate hard microspheres containing drug. This is the same photograph of the this is the without drug, and this is same photograph of the with drug of calcium pectinate. Then just to ascertain that if how much amount of the drug is released from this calcium pectinate microspheres at a different pH, we perform dissolution studies at different GIT, simulated GIT fluids, right, at different time interval. So first we use, we perform dissolution studies in simulated gastric fluid at pH 1.2, that is for 0 hours. Then after that system is transferred, a very little amount of superficial drug is released, but and then we'll transfer after 2 hours, we transfer it into the simulated gastric gastrointestinal fluid having pH 4.5, again for 2 hours, and in that very say 8 to 10% drug is released. Then again the system is transferred into the simulated intestinal fluid having pH 7.5, right? And is here again this 10%, 10 to 15% of drug is released in the simulated intestinal fluid having pH 7. This 15% drug is really either it is superficial drug which was present on the surface of the calcium pectinate microspheres, or it may be due to the swelling of the calcium pectinate, little bit swelling of the calcium pectinate microspheres. Then the system is transferred into the simulated colonic fluid having pH 7. And this study is performed 2 hours. Then we'll find that about almost 100%, 90 to 100% drug is released in the colonic fluid, where the polysaccharide enzyme is present in the simulated colonic fluid, which is responsible for the degradation of the calcium pectinate. And then we perform the in vivo studies in albumin after oral administration of calcium pectin microspheres. And after the administration of the drug, we isolated the different whole gastrointestinal tract and separate the different part of the GIT, and we have measured the concentration of the drug that is present in the stomach, small intestine, and colon. Then after 8 hours, we find that in the colon, maximum amount of the drug was present. This another polysaccharide that can be used for the making the nanoparticles, that is or microparticles, that is the guar gum. It is a hydrophilic in nature and swell in cold water forming viscous colloidal dispersion. And because of gelling property, retard the release of the drug from the dosage form, as well as it is susceptible to the degradation in the colonic environment, because in the colon, polysaccharidase enzyme is present, which is responsible for degradation of this guar gum. So here we prepare microspheres of the guar gum, and guar gum 5% solution of the guar gum is prepared, and it is drop bias into the castor oil having sponity and anti-foaming agent at 60 degrees centigrade, and stir for 10 minutes again at 1000 or 2000 RPM. And then we'll put this glutaraldehyde as a cross-linker, just as a hardening agent, right? Guar gum, when we put in the castor oil, it will be soft in nature. After adding the cross-linker, these soft guar gum particles will be hardened, and again stir it. After that, we wash it with suitable solvent, right? And then centrifuge it, again wash it, then centrifuge it, and we'll get the nanoparticle or microspheres of the guar gum. This is the same photograph of the guar gum microspheres without drug. This is lower one is the with the drug. Again, then different studies, in vitro drug release studies were performed of this guar gum microspheres containing a drug, and in different simulatory colonic fluid containing with or without red cecal content. Here it is important to understand that in the presence of the cecal content, the release of the drug is increased. The lower one is release of the drug in the simultaneous colonic fluid without cecal content, and this is yellow or green line is showing the 2% in the release studies and 2% cecal content and 4% cecal content. And so it is clearly indicates that as on in the presence of cecal content, the release of the drug is increased. It is because of increasing the degradation of the guar gum in the colonic cecal content, because cecal content will have the polysaccharidase enzyme, and that is responsible for the degradation of this. So as on increasing the cecal content from 2 to 4%, drug release is also increased from 30% to 60%, almost 60%. Okay, it is just because increasing the concentration of polysaccharidase enzyme in the cecal content or in the colonic simulatory colonic fluid. Then just to see whether this, especially the polysaccharidase enzyme is responsible for the degradation of this guar gum, or some other enzymes are also responsible. So what we did, we have induced the enzyme, polysaccharidase enzyme in the colon, all right? So how to induce this polysaccharidase enzyme in the colon? By giving the guar gum through the feed material to the animals, right? The rat will feed it with the guar gum, say 2 to 3 times with the feed material, right? For say 4 days. After 4 days, we isolated the colon and we take out the colon cecal content, right? And that cecal content was mixed and in 2 to 4% in the simulated colon fillet, and then we perform the release studies. Then we observe that about 21.31% drug is released if the cecal content is having the this induced enzymes, right? Polysaccharides. It means that cecal content is having the higher concentration of the polysaccharides, because for when we feed the animal with the guar gum, for digesting the guar gum, the bacteria will release more amount of the polysaccharides. So the concentration of the polysaccharides enzyme in the cecal content will be more if these animals are fed it with the this guar gum. Then another drug delivery system is a redox based nano drug delivery system. I will take only 10 minutes. Is it okay? Dr. Amit?
You can, sir.
Within 10 minutes, we will
You can
finish
take,
it.
sir.
Anna? Okay, no problem.
No issue, sir. You can take.
Okay, okay,
Yes,
okay.
sir.
Thank you. Well, as I told you, in case of the inflamed bowel disease, the reactive oxygen species level is abnormally increased. And that increase in reactive oxygen level we can use for oxidizing our polymers, right? So in case of the inflamed bowel disease, the 10 to 100-fold increase in the mucosal ROS is observed, especially in the case of the ulcerative colitis or inflamed bowel disease. So Wilson et al. In 2010 synthesized a polymer that is the redox sensitive polymer, oxygen sensitive polymer, that is a thioketal polymer, which is the poly 1,4-phenylenediene acetone diethylene ketal, right? And they prepare nanoparticles of this thioketal polymer and for the delivery of siRNA. So this system is especially they observe that more amount of the RNA is released in the colonic region, especially in case of ulcerative colitis, because of reacting with the reactive oxygen species. It degrades specifically in response to reactive oxygen species. This is active targeting dependent nano delivery system that we developed. One of my students work on this concept, and on this concept I received the President Award also. So it provides selective drug accumulation at the disease site within the colon using the ligand. It improves the therapeutic efficacy. It reduces the adverse reactions. The interaction between the targeted ligand and specific receptor expressed on the colon release, that concept is used. And here the targeting moiety that we use is transferring folic acid, or we can use monoclonal antibodies. Okay, so here here we use folic acid as a targeting moiety. So in case of this, we prepare nanoparticle containing the anti-cancer drug, and the surface of this nanoparticle is modified with the folic acid. So we attach the folic acid, and this nanoparticle or nanocarrier or nanoconstruct is dispersed in the it is filled in the capsule, enteric-coated capsule bearing the ligand nanoparticles, right? Here we have, in our approach, it was something different. We prepared the liposomes containing an anti-cancer drug, and the surface of liposomes were conjugated with the folic acid, and these liposomes is embedded in the guar gum or this gum matrix, right? It is these liposomes is rather we can say immobilized in the matrix of the gums, and this gum is further coated with the anti-coated anti-coated material. So it will be intact in the stomach because of the anti-coating. It will be intact in the stomach and the upper part of the small intestine. When they will get a suitable pH at the jejunum or ileum region. सब लोग पानी देना. So well, it is this. When they will get suitable pH, the anti-coating will dissolve. By the time your capsule will reach into the colon, the capsule will dissolve and surface modified nanocarriers will come into the lumen of this colon. And this, since they nanoparticles are surface modified, so they will be sensed by the say here the folic acid is used as a targeting moiety. So on the surface folic acid is there, so it will be sensed by the folic receptor, which are overexpressed over the surface of the colorectal cancer. So it will be taken up by this folic acid receptor, and through the receptor mediated endocytosis it will go into the cytoplasm of the colonic cell. This is receptor schematic presentation of receptor mediated endocytosis. Say nanoparticles having no ligands, it will not be sensed. If it is having ligand, no receptor, it will not go through the endocytosis, but the receptor are present and ligand are present. It will be taken up by the ligands receptor. It will go into the cytosol, right? It will form endosomes. It is the endosomes will go into the in the cytoplasm. Here the lysozyme enzyme will be acting, the wall will dissolve, endosomal wall is dissolved, right? Drug will come out and receptor will go to the surface for taking the another nanocarriers. This is how I prepared I told you I prepared the liposomes instead of preparing the nano particles. So the liposomes surface is conjugated with the this folic acid using the carbamide chemistry. This is using this carbamide chemistry or reactions, we modify the surface of the liposomes. Means the at the surface of the liposome, the folic acid is attached. This is the time photograph of the this drug-loaded uncoupled liposomes. This is the uncoupled liposomes. This is the coupled liposomes containing 5-fluorouracil as a anti-cancer drug. And then I told you this liposomes embolized in the alginate beads, right? So liposomes to be encapsulated containing approximately 10 milligram drug were pelleted by centrifugation. So we'll centrifuge it, the liposome dispersion, and the pellet or said the liposomes which are settled at the bottom of the centrifuge tube is separated and resuspended in distilled water, then mixed with the stock sodium alginate solution, right? So it will be mixed with the sodium alginate solution, and this solution containing the liposomes is added drop-wise at the rate of 10 ml per ml through the syringe. Now we will continue into the 10 ml calcium chloride solution. This alginate beads come in contact with the calcium chloride, calcium ion will be acting, so we'll get the calcium alginate gel beads. Stir it slowly for 1 hour to cure the calcium alginate beads, right? Then wash it with the deionized water, dry to a constant weight in a vacuum dryer. These are the same photograph of the beads containing the liposomes, drug encapsulated liposomes, and this is containing 5-fluorouracil. This is oxyplatin. This is containing the oxyplatin. Then these beads are further protected, means we have not left any room untouched, that drug should not release in the upper part of the GIT. Drug was in the liposomes was in the alginate beads, and these alginate beads were further coated with the PS sensitive polymer or entry-coated polymers. So how they are entry-coated? Entry-coated solution was prepared by first making milky latex of the etrazate as 100 using 1 molar ammonium, that is a 1.5% solution, and stir for 1 hour. And then we added this triethylene citrate was added 20% into the this solution and stir continuously for next 1 hour. Then entry-coated dispersion was filtered by passing through the 0.1 millimeter sieve and sprayed through the nozzle on the beads. And this solution is sprayed on the beads, right? So we'll get the coating in uniform coating over the surface of these beads. This is coated beads encapsulating liposomes containing 5 fluorouracil, and this is the entry-coated beads encapsulating liposomes containing L-oxyplatin. Then again, this is the schematic presentation of the how we prepare liposomes. First prepare containing the drug, right? Surface is modified with the folic acid. They will be entrapped into the beads. So this is the calcium. These beads were further coated with the etrazate S100, right? Then so there beads will be anti-coated beads will be intact in the stomach as well. Then they will reach into the ileocecal region where they will get the suitable pH for dissolving the entry-coating. Entry-coating will dissolve, right? And this beads, alginate bead will reach into the colon where polysaccharide enzyme will be acting and degrade these alginate beads, and liposomes will come out. Since the liposomes is having the folic acid as a ligand, so it will be taken up by the folic acid receptor, which are overexpressed over the surface of the colorectal cancer. So here, by this approach, we can achieve effective colorectal targeting of the anti-cancer drug. Similarly, here in the last slide, we have used multiple approach for targeting the drug to the colon, for effective targeting of drug to the colon. Similarly, we can club two approaches. Say we taking the pH-sensitive polymer as well as pH-sensitive polymer, since we know that due to the physiological changes, some of the patient may have the variation in the pH, and there are chances of release of the drug in the upper part of the GIT, so that we can prepare the nanoparticles of the pH-sensitive polymer, and these pH polymers is further coated with the we prepare the particles of the any gums or polysaccharides and coated with the pH-sensitive polymer. So they can there are dual protection of the delivery system in the that will prevent drug release in the upper part of the GIT. And by this approach, we can also achieve effective drug targeting to the colon. So we can prepare microspheres of the polysaccharides coated with the etrazate polymers, right? So it will be intake in the stomach at an acidic pH. When it will have the pH in the ileocecal part, that is distal part of the ileum, the pH is 7, so that coating will dissolve, and these polysaccharide microspheres, uncoated polysaccharide microspheres reach into the colon. Polysaccharide enzyme will digest this, will get the drug release, free drug in the colonic region. Here we prepared cross-linked chitosan microspheres. So by dissolving 4% chitosan in 5% aqueous acetic acid, in which drug is dispersed, right? And this is dispersed in the liquid paraffin having span-80 and antifoaming, stir for 2 hours, right? Then we add glutaldehyde saturated toluene solution 1 to 3 ml, so that will cross-link, harden the chitosan microspheres, and we'll get the cross-link chitosan microspheres, wash it, centrifuge, separate, wash it with the hexane, or then we dry in vacuum desiccator. Then these chitosan microspheres were coated with the anti-coated polymer. So cross-linked chitosan microspheres suspended in the organic solvent containing anti-coated material, emulsify into the liquid paraffin containing span-18 antifoam agent, stir for 4 hours, then rinse it with N-hexane, dry in vacuum dry desiccator for 48 hours. So we'll get the chitosan anti-coated chitosan microspheres. This is the top one is the chitosan, same photograph of the cross-linked chitosan microspheres without drug, and this is with drug. Again, there are different studies were performed just to see that at what pH drug will release. So very little amount of the drug is released in the upper part of the GIT, and it's start releasing drug after 5 hours, where the pH is about say 6.5 or 7, pH 7 or 7.4, right? So this is again in the presence of cecal, and then release studies were performed in the in the simulated colonic fluid containing the cecal content, right? And certainly there is a increase in the drug release is observed in presence of red cecal content. Then the simulated colonic fluid is prepared, which is containing the cecal content after the 5 days of enzyme induction. Means here the polysaccharide enzyme concentration of polysaccharide enzyme concentration is more. So we'll observe 24 to 29% enhancement in drug release if it is if the polysaccharide enzyme is induced after feeding for 5 days with the chitosan. This is another work we have performed in our lab, that is we prepare nano composites where we use montmorillonite, right? Montmorillonite and chitosan. So by layering it, layering it, we prepare nano composites containing the melsalazine, means that is the 5-amino salicylic acid. So this nano composite will have the dual advantage that the montmorillonite which we have used, this is very good for the treatment of the inflammatory bowel disease. So this montmorillonite show anti-inflammatory activity by absorbing luminal antigen, increase of the colonic mucin level, and possibly a direct modulatory action of cytokine produced by the mucosal cell. It is well documented that epithelial barrier defects induced by the pro-inflammatory cytokines has been restored by the montmorillonite. And because of this property, we use montmorillonite for targeting the for the treatment of the inflammatory bowel disease. So we have apart from this anti-inflammatory property, we also incorporated the messalagine in the layer of the chitosan and montmorillonite. So this composite is prepared, and chitosan has been intercalated by ionic exchange by negatively charged. So chitosan is positive charge and montmorillonite is negative charge. So by that interlayer composite is prepared. And it is observed by that this composite composite of montmorillonite and chitosan remarkably reduced the ulcer index 3.8 as compared to the chitosan nanoparticles that in that we were able to reduce only 7.03, and mesylagine, which was having the ulcer index 9.85. So you can imagine that about from 9.85 to 3.8, we will be able to reduce ulcer index. So this is the very new concept on which we prepare the nano composite of the montmorillonite. This is the montmorillonite is the earth metal, right? It's a like a mud. Similarly, you can use dendrimers also. If, as you know, the dendrimers are having the number of amino groups in the skeleton of this dendrimers. Okay, so and that amino groups, if we are able to create the azo bond, right, by different approaches, we create the skeleton of the azo bond in the skeleton of the dendrimers using the amino group, right? We can make these dendrimers specific for the colon targeting. So it is observed that and we can incorporate in the dendrimer, we can incorporate 5-aminosalicylic acid. So it is in this palm dendrimer we are having, which are having the azo bond in the skeleton and the 5-aminosalicylic acid. It release the 5-aminosalicylic release from these carrier in rat cecal content, although a rat considerably slower, but here rate of release of the 5-aminosalicylic is slower as we observe in case of the sulfasalazine. This is about the time release. As I told you, by just delaying the release of the drug from the carrier, we can achieve the targeting the colon. This is the first formulation. Pulsin cap was the first formulation introduced, and it is for targeting drug to the colon. This Pulsin cap is having the hard gelatin body in which the drug is filled, and the this opening or mouth of this body, hard gelatin capsule body, is capped with the hydrogel, right? And this is having water insoluble body of the hard gelatin capsule, and this mouth is capped with cap of the mouth. This is closed with the cap of this hard gelatin capsule, and the cap is coated with this anti-coated polymer. See how it will work. Say this is the Pulsin cap, okay, and this Pulsin cap, when it will be say it is the anti-coated, so it will be ineffective in the upper part of the GIT. When it will reach into the say jejunum or ileum, here they will get the suitable pH. The anti-coating will start dissolving, and it will at the end this anti-coating will be dissolved. The cap will come out, and this hydrogel will come in contact with the water or gastrointestinal fluid, right? And when it will come in contact with the aqueous gastrointestinal fluid, it starts swelling, right? Slowly it will start swelling, and this slow swelling of hydrogel leads to a lag time that is predetermined by the length of the hydrogel. So by changing the length of the hydrogel, we can monitor the lag time, we can monitor the transit time of this capsule in the small intestine. So when they will attain certain height, length, then this hydrogel will be ejected, and because of extrinsic swelling from the bottom, and drug will start releasing. So by delaying the release from the here to here, by the time your delivery system will come into the colon. So thank you very much. This is the exclusive photograph which has been taken during my award ceremony. of the President Award at the President House. So, as we know, we Indian believes in let us not follow a path set by the others. This is very important quotation. Let us not follow a path set by the others. Let us set a path for others to follow. Thank you very much. God bless you.
Thank you. Very
Your voice is not clear. Your voice is not clear.
Hello. Hello.
Huh. Yes.
Hello.
Huh. Yes.
Hello.
Yes.
Now it is fine. Okay.
Huh. It is
There was
fine. It is
a
fine.
problem of
Yeah.
internet. So it was a very illustrious talk on nanotechnology application of colon drug delivery system, and most of the participants now they can feel that we need to start working on this area, and you have given us the path how to enter into this and how to work on the colon drug delivery system. A lot of appreciation are there. We are receiving from the participants and some of them have some uh, queries since the time is not much and our second speaker is aware of that.
No, no, that gastric emptying, if it is delivered through the oral route and without any dissecting, you can just dissect the patient and you just directly put drug to the colon. So you can overcome this
Okay.
gastric time. But if you are delivering through the oral route, it will anything which is coming going through the oral buccal cavity, it will go to the stomach. You cannot overcome that gastric time. But yes, you can protect your drug from gastric degradation or gastric release from the delivery system.
Uh, Thank you, sir. And lot of questions are on microflora of the colon.
Yeah.
So somebody is asking what is the role of microflora and the drug targetability and effectiveness. One participant is asking, is there any role of gut microflora in pathogenesis of colon cancer? So can you put some light related to the targetability and the
Yeah.
microflora of the colon?
Yeah. It's a microflora, which is microorganisms which are present in the colon. As I told you, all microorganisms are beneficial for the human being, right? They are used for the digestion of the undigested food, which is coming from the upper part of the GIT. So these are all beneficial ones. And these microorganisms are releasing different enzymes. So that enzyme we can use for digesting our delivery system also, right? Sometimes as I have taken an example of polysaccharidase enzyme. Different polysaccharidase enzymes are released by the colonic microorganisms, right? And lot of you say quantity is sufficient for digesting the polysaccharides, right? So, or azoreductase enzyme that is released by azobacter present in the large intestine or colon. So, these as azoreductase enzyme is responsible for cleaving the azo bond. If your delivery system or drug is having the azo bond, then it will be responsible for cleaving for azo bond. Your drug may be released from the delivery system or from the product into the colon, or polysaccharidase enzyme is responsible for degrading or digesting the polysaccharides or different type gums, right? So that can be used for our releasing the drug in the specifically into the colon, because polysaccharide enzyme is specifically present in the colon, right? So these enzymes we can use for triggering the drug release, especially in the colon or the site where you want to deliver the drug, right? So these microorganisms which are present in the colon are very important microorganisms, and one who's having the depletion of these microorganisms, they will human beings facing a lot of problem, right? So these are the very beneficial enzymes. Okay.
Okay, sir. Thank you very much, sir. Thanks a lot. We
Thank
are
you.
overwhelmed with your presence in our FDP, and
Thank
a
you.
gesture from our side, a small gesture and a token of gratitude for you, sir, from our department. We are presenting you with the certificate of appreciation, and we constantly seek your guidance in our all endeavors, and we wish you a healthy and happy life ahead, sir.
Thank you,
And
thank
this,
you, thank you very much. Thank you very much. You can share my mobile number or email number, an
okay,
email
sir.
ID with the participants. If they have any problem, they can contact me anytime. Okay.
Sure, sir. Sure,
So
sir.
thank you very much.
Thank you, sir. Thank you
Special
very much.
thanks to Ashish and Amit Bhatia and all the faculty member, all the organizer of this faculty development.
And Uttam Kumar Mandal, he's
Uttam,
a co